Good afternoon. My name is Whitney Witt, and I am the inaugural Dean of the College of Health at Lehigh University. I am so excited to welcome you to our ongoing Population Health Colloquium Series. The Population Health Colloquium is a faculty-organized series that will continue throughout the summer and focus on COVID-19, examining the most vulnerable populations, social determinants of health, and shining a light on long-standing health inequities. I'm very delighted to introduce our webinar entitled Health Inequities in Light of COVID-19, a focus on the Lehigh Valley community, moderated by Lehigh's own Dr. Fatima Wakil. Our leading experts who will be discussing how the COVID-19 pandemic has shed a light on existing health inequities in our local community. Three leaders will discuss the root causes of health inequalities in the Lehigh Valley, the differential impacts of COVID-19 on vulnerable groups in the community, and how their organizations have worked tirelessly to address these inequities. I will now turn it over to Dr. Wakil, who will introduce our panelists. Dr. Wakil.
Thank you so much for the kind introduction, Dean Witt. And thank you so much, everyone, for joining us today. So it is with great pleasure that I introduce our three esteemed panelists. All three are community leaders whose extraordinary efforts and contributions have made important impacts on the health of individuals and families in the Lehigh Valley community. So first we have Jill Pereira, who is the Vice President of Education and Impact at the United Way of the Greater Lehigh Valley. Jill Pereira's background includes serving diverse populations throughout the Lehigh Valley. She has advanced her leadership in the United Way of the Greater Lehigh Valley over the last 11 years and is currently responsible for overseeing a $9.3 million annual investment into the areas of education, food access, healthy aging, and emergency services to ensure the achievement of the organization's goals with the community. Jill was named one of Lehigh Valley Business 40 Under 40 recipients in 2015 and was presented the National Community Schools Initiative Leadership Award in 2018. Next slide, please. Next, we have Dr. Hashan Batz, who is the Executive Director of Promised Neighborhoods of Lehigh Valley. Hashan is a prison survivor, healer, son, father, brother, husband, and friend. In addition, Hashan is a community epidemiologist, community-based participatory researcher, and leading expert on trauma-informed care, reentry, and community engagement. In addition to being the executive director of the Promised Neighborhoods of Lehigh Valley, he is an adjunct professor, Lehigh University postdoctoral research fellow, Writer Pool Collective Impact Fellow, Practitioners Research and Scholarship Institute Writing Fellow, Distinguished Robert Wood Johnson Culture of Health Leader, and founding member of the Society for Healing and Study of Historical Trauma, founding member of the Northeastern Pennsylvania chapter of the National Association of Black Social Workers, and board member of the Resurrected Community Development Corporation and Penn State Extension. Hashan holds a joint Master's of Social Work from North Carolina A&T State University and the University of North Carolina at Greensboro, a postdoctorate certificate in global health, and a doctorate in health sciences from Nova Southeastern University in Florida. Next slide, please. So last but not least, we have Kristen Renrich, who is the director of the Bethlehem Health Bureau. Kristen Renrich has worked in the field of public health for more than 20 years. Ms. Renrich was appointed to the position of Director of Health for the City of Bethlehem on January 7, 2013. She joined the Bethlehem Health Bureau in September 1998 after graduating from East Stroudsburg University. In May 2004, she earned her master's degree in public health from East Stroudsburg University and received her certification in public health in 2008. In her role as health director, Ms. Renrich focuses on diagnosing the most pressing health issues in Bethlehem, identifying the most effective strategies to improve health, and collaborating with community partners in an effort to fulfill the Health Bureau's mission of creating a healthier Bethlehem. So before we get started today with our questions, again, I would like to extend a warm welcome to our panelists and thank them all so much for joining us today. Next slide, please. So the first question that I would like to pose to our panelists is, can each of you please share a little bit about the missions and goals of your organization, as well as what your role entails within your organization? And I'm going to start with Jill, please.
Sure, great. Thank you so much, Dr. Wakil, and thanks to Lehigh for the invitation to participate on this panel. I feel really blessed and fortunate to have relationships with both of the other panelists, Dr. Batz and Kristen Renrich. And it is how so much work gets done in the community. So I am the Vice President of Education and Impact with the United Way of the Greater Lehigh Valley. And in short, United Ways were created as a charity organization to raise money to do good in community. We have over a 125-year history and have been evolving over that time. So I would say today what our United Way's mission and goals are, we are an organization dedicated to advancing complex social change issues in our community and finding solutions to those social change those social issues. And we raise money in order to do that kind of work. Where 100 years ago we were raising money and doing good things, we're doing good things first and needing to raise money in order to advance those goals. So we have population level goals related to education, ensuring all kids read on grade level by the end of 3rd grade is a really key milestone to future life success. We have a key goal around increasing the number of individuals who have access to nutritious, healthy food, increasing the number of older adults who are community connected and have the supports they need in their homes in order to stay independent and thriving. And we have a goal around ensuring that we always have a safety net available in our community through the support of nonprofits and organizations that provide those safety net services. So my role in the organization is really to understand what the needs are in our community and to help build some of the strategies that we will ultimately invest in to drive the changes that are needed in order to meet those big population level goals. So I come at this from the perspective of a social worker and thinking about how systems interact with one another and recognizing that people are at the forefront of all change and are the beneficiaries of the change that we're seeking to create. So more importantly, in everyday life, relationships and meeting community where they are has become front and center for our United Way.
Wonderful. Thank you so much, Jill. Now we'll go to Dr. Hashan Batz. Oh, I think you're on mute.
I was saying, well, I'm done. That was everything there that I had to say. No, I was saying thank you for having me, Dr. Wakil, and it's exciting, as Jill said, to be with my peers whom we work with, right, on a daily basis to do the work that needs to be done across the valley. So I'm the executive director of the Promised Neighborhoods of the Lehigh Valley, and we are an anti-racist liberation-based organization that is centered in cradle to career. So the idea is that every child in Allentown graduates high school ready for the next phase of their lives. And that's whether it's vocational training, whether it's entrepreneurship, whether it's college, university, whether it's military, whatever it is that they want to do, we want to make sure that they have all of the things they need, the environment that they need to be successful, and that's through a lens of the social determinants of health. So we look at things like prenatal care, which is your specialty area, Dr. Wakil, right? We make sure
Yes.
they have the mental health supports that they need, safe communities, make sure they have the economic opportunities. And with our recent 3-year plan, we've been focusing on how do we build community capacity and how do we build the capacity of parents. So in the recent past, what we've done is we're enhancing and building the youth to have the great opportunities through strengthening their parents around leadership, around community engagement, around community activation, around relationship building, and also community capacity building.
Wonderful. Thank you so much, Dr. Batz. And then now I'd like to go to Kristen so you can share a little bit about your organization.
Thank you. Good afternoon, and thank you for having me. So the Bethlehem Health Bureau is one of 10 county municipal health departments in the Commonwealth of Pennsylvania. Pennsylvania is unlike most states, where in most states you'll find that every county has a health department. So I think the COVID pandemic really shed a light on the lack of public health infrastructure in Pennsylvania, and many communities are now discussing the formation of a local public health department in their jurisdiction because they saw discrepancies between communities that had a local public health department and those that did not. Specific to our organization, the mission of our organization is to provide high quality public health services that protect and promote optimal health and well-being to assure that Bethlehem is a safe and healthy community. We have a diverse staff of 24 individuals with backgrounds in public health, social work, nursing, nutrition, environmental health, and various social services. We have 4 major divisions. We have a maternal and child health division, environmental health, chronic disease and public health emergency preparedness, and environmental health. So within the scope of those 4 program areas, we provide clinic services. So we have STD and HIV clinics, as well as immunizations, family planning, and tuberculosis. We also conduct home visiting programs for high-risk populations, provide community-based education and prevention activities, conduct food inspections, and disease investigations, just to name a few. Directly related to COVID, as you can imagine, as a local public health department, that's been our life day in and day out since the pandemic first started in March. Sometimes it feels like Groundhog Day. We're starting to get back to some of our regularly scheduled programming, but it still is pretty much all hands on deck dealing with COVID-related issues. So we conduct all the investigations for any positive case in Bethlehem. We conduct the contact tracing. We're providing education to the general public and businesses in the community. We are doing inspections, going out and visiting businesses to guide them and provide education, and also make sure that they're adhering to the governor's orders. And we're assisting with reopening plans. Schools, colleges, and universities, we're dedicating a lot of time right now to making sure that these places can open in the fall and welcome back students. As far as my major role at the Health Bureau, I'm obviously, as a health director, I oversee the daily operations of the department, directing public health programming and clinical health services, monitoring health data and trends. We just recently conducted a community health needs assessment, which I'll talk about a little further on today. Allocating public health funds and resources as appropriate. As Jill alluded to, none of this happens without collaboration. So collaboration's at the heart and soul of a lot of what I do, and having those relationships, because no one organization is going to move the needle alone. Developing public health policies, enforcing public health laws, and generally just assessing those needs in the community and making sure that we have the programs in place to address those needs.
Wonderful. Thank you so much, Kristen. So I'd like to bring up the next question to the group. Next slide, please. Thank you. So from your vantage point and experience, what are some of the leading health inequities in the Lehigh Valley community? And what do you believe are some of the root causes for these inequities? I'm going to start with Jill Pereira.
Yeah, great. Thank you, Dr. Wakil. So I've thought a little bit about how to answer this question, knowing all of the work that we do. None of the work that we do is directly related to health. It is all related to the social determinants of health, right? And so every aspect that we touch in the community, whether it's supporting older adults or supporting food assistance, folks with food access, or education work, and certainly emergency services, lends itself to looking through that lens of social determinants of health. And so what we've been spending a lot of time and energy kind of unpacking over the last couple of years is the impacts that toxic stress has on people in general, but mostly young children. And thinking about, kids who are in situations that they themselves didn't choose, and families who are in situations that they themselves didn't choose, but how day over day, when you don't have enough food, or there is neglect or abuse happening, or there is some sort of violence that's happening, some of the internal things that are happening to your body physiologically, and then what that does when you're entering into the school day. And how that creates those inequities later. You're not learning. And so if you're not learning the materials, if you're not in a pre-K setting, you are in a kindergarten, but you're not actually open to learning the material that's being presented to you. It doesn't matter if you have the best teacher in the world in front of you. You're still not going to be absorbing what you need to be competitive with your peers and to be growing and achieving when you're moving into first grade and so on. And so I think, all of the challenges we have around unemployment and housing stability and graduation rates and young people graduating from high school feeling like they don't have a place and they don't have what they need in order to have the place that they want in our community. Much of that is rooted in this place of toxic stress in households. And since the murder of George Floyd, we've done a lot of work in unpacking internally in our organization what it means to be connecting the dots between health disparities and toxic stress and trauma and structural racism that exists. So I think there's a lot of conversation happening right now and a lot of folks with a new appetite and a new awakening to start talking about that structural racism, which is at the root of so many of those health inequities that we see later on.
Thank you so much, Jill, for those amazing insights. And I'm going to turn it over to Dr. Hashan Batz to tell us more. I think you're on mute. There we go.
Yeah, so can I just say ditto to everything that Jill said, right on, Jill. So the inequities are huge, they're large, and we see them again through the social determinants of health. I would say to add to what Jill said, allostatic load is one of the key drivers. And when I talk about allostatic load, we're talking about the wear and tear on your body that toxic stress Jill spoke to has. We're talking about the trauma of racism. I mean, NYU has a report called exactly that, the trauma of racism. And it talks about how it beats down on your body and your psyche. So when we talk about allostatic load, you know, we look at the chronic diseases and killers, and we look at things like diabetes, like hypertension, like high blood pressure, and that's where you're going to see the inequities. That's where you're going to see everything show up when we look at communities of color, when we look at vulnerable populations, when we look at communities that are wrestling with poverty. You're going to see the outcomes in life expectancy. You're going to see the outcomes in disability, higher levels of disabilities, daily disabilities. You're going to see the outcomes in all of the indicators around health and life outcomes are going to be higher in communities of color in the valley that we work with. So I would say some of the root causes are racism. You know, that's something we don't talk a lot about, but we are talking about it now, right? So those are some of the root causes. Poverty are some of the root causes. And again, which is centered around the inequities of education, of housing, of all of the drivers of, you know, these poor health outcomes that we're experiencing. We see them all, and we see the outcomes of all of them. And then one of the ones we really focus on at Promise Neighborhood is, so our programs are broken down with 3 specific goals. That's to increase hope, increase sense of belonging, and increase agency, which is I can make a purposeful decision in my life and in my community. So just to speak to the one of belonging, we know that isolation kills. You know, we know isolation is deadly. So we want people to know that they belong to community, a community that cares about them, a community that's welcoming, and just that one indicator will improve health outcomes tremendously. Thank you.
That's excellent. Thank you so much, Dr. Batz. And then now I'd like to turn it over to Kristen Renrich.
Thank you. And again, I concur with both what Jill and Hashan have stated. You know, one thing I think is important to note, now I've been in public health over 20 years, and I've seen the seismic shift in the way public health was when I first started in my career to where we're at now. When I first started in the public health field, we were focusing on singular health issues, and we were not talking about root causes at all. When we looked around the table, it was all individuals and organizations that were from related health fields. So I definitely have seen that transformation over my career in public health for the better. I think we've made some great strides locally on focusing on the root causes and partnering with organizations from all various sectors, recognizing that transportation, zoning, education, business community, they all have a role to play in focusing on these social determinants of health. I mean, although we made significant improvements, I think everybody can agree we have a long way to go. I think we're just hitting, you know, the tip of the iceberg. So with that said, we completed our community health needs assessment in the fall. So we conduct a community health needs assessment every 3 years. It's a requirement of an accredited health department. And we do that to identify our gaps and our needs in our community, and then we develop a plan to address those identified needs. Our data continues to improve every time we're doing a community health needs assessment. Years ago, when we first started doing needs assessments, we were just collecting data in aggregate. So it was just for the city of Bethlehem, what the health outcomes were, the health behaviors, mortality. So it really can give you a false sense of what's going on in your community, because everything could look well when you're looking at data in aggregate. When we started breaking things down into subgroups, you can definitely see clear disparities. And I think we constantly are getting better as a smaller community. Sometimes it's difficult to get that data down at a city level and then break that down further into different subgroups, but we're definitely improving in that area. And it's shedding a light on just how many of the health outcomes and mortality and different data indicators are showing that glaring difference in populations. If you look at anything from maternal and child health indicators to HIV, STDs, diabetes, asthma, looking at those indicators by race, ethnicity, and income, there are clear, stark differences. And as I said, income and race, I think, play a huge role in creating those disparities. There is a recent study that was conducted from UCLA that showed the health of wealthier Americans has remained relatively stable, but when looking at the lowest income groups, their health is declining substantially. So there are some clear differences in income levels, which isn't anything surprising. And of course, income impacts where you live and housing. And there's been a lot of research over the last few years showing that you can have neighboring zip codes and they could have very different health outcomes. So looking at the location and making sure that, where somebody lives, that they have access to good schools and healthy foods, affordable housing and jobs, that's all key to creating, a robust community and leveling those health outcomes among different communities.
All right, thank you so much, Kristen. I really appreciate that. And to all of the panelists on all of your great insights and wisdom. So the next question that I have is, how has the COVID-19 pandemic further impacted these health inequities in the Lehigh Valley community? And I think the first response, if you don't mind, Dr. Batz, if you can take it, if you can answer.
Yeah, so this is a great question, right? And to start by summing up what we found is that the people that were wrestling with challenges like food insecurity, housing instability, their issues just got larger. It just exacerbated the challenges that they had. What it also did, this global pandemic, was people that were stable got pushed to the margins. So we had this new population of people in need that had never in their lives been in need. So that created like this swell of need for food, need for economic support, need for even from a mental health perspective. People weren't prepared to deal with the uncertainty. I mean, this global pandemic has put us in a place where I like to say my grandmother and my elders can't even tell me how to manage it because they've never experienced this before. So there's a lot of fear, a lot of uncertainty that came about. And again, at the neighborhood level, the people that were already struggling, the people that were on the fringes, were pushed further, deeper into poverty, were put at greater risk. So you have people that were living like 12 people in a 2-bedroom that had relatives come from New York City to stay with them, escaping, the impact of the pandemic there. So we knew early on that there were going to be some huge disparities, just because we know the nature of public health outcomes. We know the nature of, communities of color. We know the natures of economics. So we really worked with our partners to say, well, how do we protect and support those who are going to be most impacted, those who are most at need? And there were some things that we put in place we'll talk about a little later, I believe.
Thank you so much, Dr. Batz. And now we'll go to Jill Pereira.
Yeah, I'll just expand a little bit from our perspective at the United Way and what Dr. Batz was just sharing. About a year and a half ago, there was a report put out by United Way of Pennsylvania about a population they referred to as ALICE, A-L-I-C-E, and it stands for Asset Limited Income Constrained Employed. And pre-COVID, I believe the number was about 1 in 4 families across the state were kind of falling in that ALICE category. And so they weren't quite poor enough to meet the threshold for state and federal support, but they certainly were not making enough money to be able to make everything go well. And so they were kind of living on the edge. And in February, we as an organization we had been socializing the ALICE data. We had been starting to break it down by counties. We cover Lehigh, Carbon, Northampton, and starting to really gear ourselves up to be addressing not just the really high need communities, but also this pretty large ALIS population across our community. And then COVID hit. And so we had been referring to the ALIS families population as families that are one crisis away, one paycheck away from crisis. And you can imagine how that number has then, we haven't seen new data fully, but anecdotally what we know, and from all of the other data that we do have, like that number of families that are now living in that place where they, it's just different. Life is different from that for them significantly than it was pre-COVID. And so we are trying to regroup around what does that mean? How do you continue to go deep in resource and support a larger population in your community that has now the same deep needs that previously you were starting to get your arms around in some sort of systematic way? It is a huge challenge, and it covers everything from housing is certainly a huge challenge that's coming with the eviction moratorium being lifted, and all of the work that's happening in that space, and food, and then certainly with our education system still being working on figuring out what does the next journey leg look like for them. It's really important that we continue to keep our eyes on and our hands moving in work around the ALIS population. So those ALIS, the folks that are living in that situation. Asset limited, income constrained, employed. I'm sorry, I lost my acronym for a second.
That's great. Thank you so much, Jill. And then I'd like to go, move it over to Kristen, if you'd like to share, please.
Sure. So it goes without stating that the pandemic definitely has shed light on inequitable health outcomes. One key issue that we saw early on in Pennsylvania, as well as other states, was there was lack of collecting race and ethnicity data early on in the pandemic. And this was something that typically when you're dealing with disease like coronavirus, when somebody gets tested, the lab submits those results into a national database. So the labs were not collecting that data, therefore it was falling through the cracks. We saw this gap early on. We collected the race and ethnicity data when we were conducting our investigations, and it was really key into providing us insight into what populations were contracting coronavirus. We saw very early on that the Hispanic population was significantly impacted in our community, which then led us to reach out to those leaders in the community to help assist us with messaging. So it definitely was very important to be monitoring that data. And I think the state, it was a little too late by the time they came out and were encouraging others to collect that data. So now we don't even have a full picture really of which populations were impacted comprehensively. Data has shown, though, at a national level, that African Americans are 4 times or 5 times more likely than white Americans to be hospitalized due to COVID. Hispanics are 4 times more likely. We saw in Bethlehem, with looking at our data, that 8% of our white cases were hospitalized, but 18% of our African American cases were hospitalized, and 17% of our Asian population were hospitalized. So you're seeing some stark differences there. And again, it's important to know this information so we can better target our programming efforts and our messaging. When looking at certain risk factors that created these significant differences, first and foremost, one key issue was individuals with chronic diseases such as asthma, diabetes, heart disease. They were hit harder by this pandemic. So they got sicker. They are more at risk to die related to COVID. And when you look at the populations, when we're looking at our data, those populations that are more prone to diabetes and asthma and heart disease, it tends to be those same racial and ethnic groups. So, that's one point that's out there. Then we look at the jobs. So those essential jobs during the pandemic, the grocery store workers, those working in nursing homes as nurses' aides, the bus drivers, the warehouse employees, they all continue to work during the pandemic. So therefore, it was putting them at, an increased risk in their workplace. You topple that with the fact that some of these jobs don't have paid sick time. So individuals were very scared to go to the doctor and get tested because they didn't want to have a positive test, even though they might have had symptoms, because that would mean that they need to miss work and potentially not get paid. So I think it shed a light on the sick time as well, and the lack of sick time, universal sick time in this country. The lack of adequate information, again, if you're not tracking that data and monitoring for which populations are more impacted than others, I think some of the messaging was off maybe with some of the communities, or wasn't necessarily happening. So I think that was a key issue, crowded housing, which Hashan had spoke to. So you have individuals that may have multiple families living in one household. One person gets sick, that easily exposes the rest of the individuals in that household to coronavirus. And then we didn't really see this too much in our community, but other communities with lack of testing or testing sites that weren't located in specific pockets of the community where testing was most needed. For people that didn't have transportation or resources to get to those testing sites, or if they didn't have the assurance or couldn't afford to pay for a test, those were all various barriers. And again, I think that when you're looking at all of those factors, those contributed to the numbers that we ended up seeing. And then lastly, just the after effects of coronavirus. So we talk about this as a population as a whole, mental health, delaying care, unintended pregnancies, looking at poverty and how that's going to be impacted. So that's impacting the general population, but then again, when you're looking at certain groups, you're going to see them impacted more so than others. So I think there is going to be a lot of fallout and a lot of additional health issues that we're going to be tracking for years to come based on this pandemic.
Thank you. Thank you so much, Kristen, and all of the panelists for your detailed and thoughtful analysis of really how the COVID-19 has further exacerbated existing health inequities in the Lehigh Valley. And then the last question that I would like to pose to you today is, can you please just discuss how you and your organization have helped address these health inequities during COVID-19 and how you continue to help build community resilience within the Lehigh Valley? And I'd like to start with Jill.
Yeah, sure. So we've taken a couple of different approaches to how we've been supporting the community at large. And again, those social determinants of health with our populations. We've spent a lot of time communicating lots of information, primarily aimed at the nonprofit sector, knowing there's a lot of nonprofits in the Lehigh Valley, and folks that are accessing services are typically accessing them through those nonprofits. So early on started convening weekly calls with community nonprofits to share information from health experts on what was the status of the current health crisis underway with COVID. And then over time also pushed in areas around problem solving community issues related to food distribution or PPE supplies and things of that nature. So really using that as a forum to keep open communication with community. We've also spent quite a bit of time mobilizing people and resources. And so as the largest charity in the world, we have connections to lots of large corporations and their employee base and their leadership and donors. And so we have spent time mobilizing donors to understand both what the needs are of real people in community and of the nonprofits that are set up to serve people in community. And so that has played out in lots of different ways. We've done many virtual impact experiences over these last couple of months. And then we've also raised money. We've raised money and we have deployed money very quickly out into the community. And in the first, we created something with some partners, Hashan being one of those, around aligning resources across systems leaders and making sure we have a grassroots perspective in that group called the Strategic Response Team. And our core mission in the first couple of months was really to raise money and then deploy it through a rapid, informed decision-making process aimed, again, mostly at smaller nonprofits or nonprofits that were meeting critical needs around food, housing, and income supports, and serving populations most impacted by the COVID-19 pandemic. And so that team has kind of shifted. We're looking more intentionally now in rounds 3 and 4 of that funding towards supporting racial equity. And knowing that there is a huge link between the conversation around race equity and what has happened with the COVID-19 pandemic right here in our backyard. So those are a couple of the ways that we have been moving work out in community from a systems level. In actual work, we've gotten our hands into, and Hashan has also led some of this, diaper distribution, recognizing nobody has approval for diapers previously as a basic need, and that came up as a basic need And also, we've done some really important work through my colleague Beth Tomlinson and Resilient LV around social emotional learning tools for kids, for families, for community members, and for educators as we start to think about the midterm to longer term social emotional effects that this pandemic and isolation is having on our young ones, and how to kind of mitigate some of that. And then we've also led a child abuse mitigation campaign out in the community, to county, across sector, to really activate all community citizens as mandated reporters, knowing that the incidents of child abuse are likely really increasing with all of the stress and unemployment and instability. And yet the reported numbers of child abuse are way down. And we know that's because people just don't have their eyes on our young people the way that they had previously. And the same is true for domestic violence. And so calling some additional attention out in our community around those areas has been really important to us over these past couple of months.
Thank you so much, Jill. And I'd like to move to Hashan, please.
So when COVID first hit, we didn't know what to do. And what we decided to do was to pause and to listen to our neighbors and to talk to people and to do some light surveying to see where the concerns were. And the first thing that became evident to us was that there's a huge distrust and disconnect between the healthcare sector, public health messaging, and the vulnerable populations, communities of color that we serve. So we had to find a way to really to remix the messages. Like, people didn't believe COVID was real. People were with some conspiracy theorists. I mean, and this is due to a long history of medical apartheid, of abuse, of exploitation, that's really grounded in some truths. So we had to recognize those, and we said what we wanted to do was we decided to do what we called consistent messaging from trusted messengers. So we took World Health Organization information, we took CDC information, and we put familiar faces, local faces to it. Same messages, hand washing, social distancing, but we put people that are community attractors, that are community influencers, so that when you receive the flyer, you saw a face that you recognize. When you saw the video, you saw a face that you recognize. We set up a web page that's called Allentown versus COVID-19, with just videos from people that have large followings that are really connected at the community level to protect the communities that we saw that were most at need. The other thing that we heard was, Joe spoke to this, we heard that if you recall, people were running out and buying diapers. Diapers were being rationed. We found out that this was not diapers, toilet paper. People run out buying toilet paper. We found out that diapers are toilet paper, right? Just for children. So families with small children let us know that they were in huge need of diapers. And then we had some gang members that we had been working with prior around violence prevention that said to me, we want to help. What do we do? So we set up a hotline where people could call and let us know what their needs are. We set up a diaper delivery service. So we were going door to door with diapers, door to door with food. We canvassed the neighborhood with those flyers that I talked about that really told people how to protect themselves and let them know that they weren't alone, that we're here. We set up a mass texting service where people could get information on what was going on in the community, and just updates from it. COVID really showed us how trusted we are in the community at the neighborhood level. And we had to leverage that by listening to the community and by pivoting immediately, because we're not a crisis service. But we identified 3 levels. We said COVID crisis response, COVID resilience, and then COVID crisis, COVID recovery, and then COVID resilience. So we're at the recovery stage now. We're not handing out the diapers. We're looking at how do we support people in recovering in terms of economic recovery, in terms of rental stability, in terms of what does their lives going to look like moving forward, and how do we support them in that with their mental health and things like that. And next we'll get to the COVID resistance and how do we strengthen our community, build capacity of our community, make sure the resources are able to reach us seamlessly in the future when there's a crisis or emergency preparedness of this size.
Thank you so much, Dr. Batz. And now I'd like to turn it over to Kristen to share.
It's hard going last all the time. I do first want to just give a shout out to the United Way. I think that they played a critical role during the pandemic with convening all the nonprofits together and holding those forums every week. They helped, I think, reduce duplication, identify issues, and really had organizations working together to address the needs of vulnerable populations. So I think that was extremely beneficial throughout the pandemic. Then I want to talk a little bit in general terms as far as what our department is doing regarding health inequities, and then I'll talk specifically about COVID-19. So as I stated earlier, we did the community health needs assessment, and then as a result of that community health needs assessment, we developed our organizational strategic plan as well as our community health improvement plan. And we made a decision early on that health equity had to be embedded into both of those plans. And this was something we recognized prior to the pandemic, and then throughout the pandemic, we knew we were right on target with having so many of these initiatives in our strategic plan. So some of the things that we're looking at doing over the next few years, more staff training around racial justice and health equity. We have a workforce development plan, so we've ingrained this into our plan for our staff. Integration of non-medical vital signs. We're looking at implementing a social determinants of health screening into our clinic and home visiting services. So we want to make sure that we're not catching people downstream, but we're looking at, prior to somebody losing their home or prior to them having issues obtaining food, that we're able to conduct this screening to connect people to the resources that they need earlier on, because I think so much effort and attention is focused after the fact. We're looking at hiring an epidemiologist. We're a small health department, so we don't have an epidemiologist. Data is split out among several staff members, but we really think it's a good use of grant dollars to hire an epidemiologist to help us build some of these data systems where we can start looking at these different subgroups, different locations and pockets of the city that are experiencing different health outcomes and disparities. We're also looking at fully implementing health in all policies, the health in all policies approach. It's something that we're doing, but it's not done comprehensively throughout our organization. So that's really working with, again, sectorial partners and making sure when policies, whether they're social or economic, when policies are being discussed prior to being implemented, that we're looking at those health ramifications and specifically the health equity ramifications around creating policies. We're also looking at creating a community advisory committee. This was something that actually was a gap when we applied for accreditation several years ago. We are really good, our staff are really good at developing programs, but we really recognize the need for community input when we're developing programs. We started getting the community more involved when we develop materials. So before we send flyers or brochures out into the community, we've had the target population review that information. That's been extremely beneficial because there's not one time that we haven't changed our messaging based on the feedback. So we'd like to expand that and have a small community advisory board, diverse members from the community that are really helping us as we're formulating our plans and our programs, that they can give input to the plans. How should we be delivering the programming? Where should we be delivering the program? What kind of messages should the programming entail? So we're really looking forward to getting that off the ground in the next year. And we're also looking at diversity in our staff, in the boards. So we have a board of health, and as I stated, we're looking at this community advisory board. We want to make sure that our boards and our staff are reflective of the community that we serve. And then lastly, in our community health improvement plan, we're focusing on disparities related to STD and maternal and child health outcomes. We're also looking at housing, mainly substandard housing. I know there's a lot of talk about affordable housing, but for some folks, the housing that they can afford is doesn't necessarily meet appropriate codes, and it's considered substandard housing. So that has its own issues, own health issues that are complicated by those factors. We're looking at stigma related to mental health and substance abuse as well in that plan. So that's just from a high level as an organization what we're looking at. And then specifically to the COVID pandemic, there was a lot of work we did around housing for the homeless. So there were two issues. One is we were under stay-at-home orders. Well, for some folks, they didn't have a home to stay at home. So we worked with New Bethany Ministries and using some of our grant funding to provide housing for these folks. And then it gave New Bethany time to work on getting them into more permanent housing, because there are a lot of folks that are couch surfing, staying with others. So we wanted to get those individuals into some temporary housing and then transition them into permanent housing. We also had an issue with the homeless population. If they either tested positive or they were in contact with somebody who was positive, they didn't have a place to go to isolate and quarantine. So we worked and partnered with a local hotel to house those folks to reduce the spread of disease in the community. Food access was a big issue, especially for individuals that were under isolation and quarantine. They might not have the means to use some of those food delivery services, so they couldn't leave the home, had difficulty obtaining food, so we provided support to make sure that they had food access while they were under isolation and quarantine. And then, as I stated earlier, we collaborated with many community agencies and community groups to assist with targeting our messaging to certain populations. And then the elderly piece is something that we're working on with social isolation that I think Jill touched upon it earlier. It's been a key concern prior to the pandemic, and more so with the pandemic when you have elderly folks who haven't been able, still haven't seen visitors and are still pretty much shut in. Social isolation is a huge concern. I know the Department of Aging for the state, they have a specific plan related to social isolation, and we're looking forward to working with them on that because we're still in the midst of a pandemic. We're not sure what's going to happen with the quote unquote second wave and where we're going to be in the fall. So we're continuing to move forward and continue to address the disparities in these vulnerable populations.
Thank you so much, Kristen. I have to say, listening to all three of you, I'm so humbled and awestruck by all of your contributions and efforts to really address the multiple determinants of health and to help achieve health equity and in the Lehigh Valley and making it a more resilient community. So now I'd really like to turn it over to our audience to answer some questions that the audience has. And I have a few questions up already. So the first question that I see is, how much do you think the balance of working and educating your children at home has impacted the mental health of households in the Lehigh Valley? And is this a major concern with the ALICE group? So I know that Jill had talked about the ALICE group. So Jill, would you like to address this question?
Yeah, sure. I don't have any hard data on this, but as a mother of 3 school-age children myself, 2 school-age and 1 pre-K, it is a whole different world when you're trying to work from home and you're trying to educate kids. And I would say, unfortunately, my kids got the short end of the stick. And my guess is, as I'm talking with colleagues and others, that is true across the board, that if you're working and your first commitment should be to your kids, but is to your work, something's going to have to give. And there's been a whole lot more screen time than would be ordinarily in play. And so it is something that we're concerned about. We are circling up with our school district leaders and others to
Perfect timing.
Keep an eye on that. Yeah, there you go. Perfect timing. Thank you. Thanks, Hassan. So it's a major stressor, and I don't think it's just for the ALICE population. This COVID has pushed everybody into a different scenario of trying to figure out how to manage lots of different things, and more so extreme for the ALICE population.
Thank you so much. Thank you so much, Jill. And do any of the other panelists want to weigh in here?
I mean, I just want to echo what Jill said and go back to what I said earlier. So the people that were struggling prior to COVID are struggling even more. So that's whether we're talking about struggling with childcare, that's whether we're talking about struggling economically, that's whether we're talking about struggling with some behavioral health challenges, struggling with domestic violence. They're struggling even more than they were prior to. So we've seen that anecdotally exacerbating within the communities that we serve. And have had to respond accordingly, right? We've had to respond with safety teams. We've had to respond again with hotlines. We've had to respond with, proactive ways to support people and have real conversations. So we don't cover a large geographic area really. So we know a lot of the people in our neighborhood, and we've had to say, how are you going to manage your anger during this time? We know the guys and the girls that have some anger challenges, and we know they're stuck in the house together, and we know there's a baby crying, and we know that they've lost their job. We know these things. We know who their landlords are. We say, how are you going to deal with this? How are you going to manage it? What kind of outlets do you have? So there's this idea of community-based organizations having relationships this will only happen through relationships, with the success and the healing and the wellness that we need.
Yeah, Dr. Wakil, if I could just say one other thing about this, want to plug our community school work. We may have 1 or 2 on the call, given that Lehigh is a lead partner in our community school work. Community schools are really about partnering, putting somebody in a school building that is not an educator, that partners with the educators, but also with the community to meet the needs of kids and families. And during COVID, and I think it speaks to this question around how are we ensuring that our families have supports that they need in order to survive during the COVID pandemic and educate their children at the same time. Our community school coordinators across the region have really rolled up their sleeves and have been amazing relationship builders with families, checking in with kids and families, making sure that they have the basic needs met. And then I'd also give a shout to the educators who have had to think really creatively about how to make sure they're engaging with kids and families differently to check in on the social emotional needs that they have so that education can still happen.
Thank you so much, Jill. So I have another excellent question here. Someone had asked, how much does the mandatory mask wearing policy, how has it disproportionately affected marginalized groups? Can they afford to protect themselves, and or do they have the resources to get or buy masks? So if any of the panelists want to take this one on.
So we all pulled together to provide masks. You know, masks were donated, masks were made and donated, larger organizations donated masks, all kind of PPE materials. You know, we got some stuff from United Way, we got them from several different places. And at PNLV, what we did is we went door to door and we provided them for people. And we blasted all over social media. If you need masks, if you need equipment, call us and we'll deliver it to you. So the first part of it was really getting past the distrust of the messages that were coming out and getting people to recognize that they did need to wear the protective equipment. And then it was getting it, which our community did a phenomenal job. I mean, we got sanitizer from, and I don't know if Jill can speak more to this or Kristen, but like the people that make alcohol made sanitizer and just gave it to us. Like it was phenomenal. And we could take it to people within the community so they'd have it.
That is excellent. Does anyone else want to weigh in here on this question?
I'll just say from a systems perspective, everything that Hashan is saying is true. And being able to tap into the state government, so PEMA made available 125,000 masks. And there were a couple of nonprofits that came together and very quickly figured out where could we warehouse them, how could we distribute them to nonprofits to make sure that they get out to people in community. And I also know that this is one of the concerns that our educators are having as our school district leaders are thinking about what does a reopening plan look like, making sure that all of our students and staff, teachers are able to be protected, that they have the materials that they need to be safe returning to a school environment is top of mind.
And I want to add, so COVID was about everyone showing up as human beings. As Jill's speaking, I'm thinking like Marcy drove to us and handed us masks. You know, and she's the executive vice president. What's her role? She's executive VP at the United Way. She drove to us to bring us these masks. Like everyone had to show up. Everyone had to find a way to contribute to making this better. And we saw our community show up big time.
That's wonderful, thank you. So I actually have a great data question here. And someone has asked, do we at this point have reliable shareable data on socioeconomic indicators of the impact of COVID-19 on low-income communities in the Lehigh Valley?
I haven't seen anything locally, just more so from a national level. We have a data dashboard on our City of Bethlehem's website, but that's basic demographic information. So it'll show race, ethnicity, it'll show age, gender. So you can see the breakdown of the cases of COVID and then who's been hospitalized, but we don't have any other socioeconomic indicators.
That's good to know. So we definitely need to collect more data locally. Absolutely. And so Kristen, while I have you here, there's a question that was really aimed for you. You mentioned that some of the messaging was off when you discussed COVID-19 inequities in the Lehigh Valley. Can you share some of the learning lessons and how messaging was then adjusted? How are we targeting Hispanic communities?
Sure. So I wasn't necessarily talking specifically about the Lehigh Valley. It's just what I've heard collectively from public health colleagues. I think we did a pretty good job here locally. And that's where it was important to collect data to then drive where your messaging needs to be. So I had worked with leaders in the Hispanic community and we worked with churches. There were several Hispanic churches that chose to remain open during the pandemic. So it was very important that the individuals going into those religious institutions had the appropriate education and information so that they could best protect themselves. So we did a concerted effort and worked with key leaders in the community on creating our messaging that went out to the religious leaders. So that was just one example. We did the same with the African American community. We had tapped into the NAACP, and they had assisted with providing some guidance on where we should be relaying our messaging, because part of what we heard from leaders was there's so much guidance, and just even coming at it from a public health standpoint, guidance is changing almost on a daily basis. It is so difficult to keep up with guidance. And that's somebody that's working in the field. So you take somebody that's working out in the community, maybe there's language barriers there. So the messages they received early on, as things were continuing to progress and things were changing, they weren't aware of some of that information. So that was an important take home for us, that we need to make sure that we're getting into those communities and letting them know when guidance can change, because people thought it was still okay that, well, I'm gathering with my family members, even though they're not part of my household. I can gather with my family members, even though it's grandmother and cousins and aunts and uncles living in different households. So we saw, some spreading of the virus that way, because people thought that was okay.
Absolutely. Thank you so much, Kristen. I actually have a question here that's really aimed for Jill. So you mentioned how important the United Way of Greater Lehigh Valley has been in connecting nonprofits to information. I imagine staff of these nonprofits are strained as they balance essential services, often in high-risk settings. Are there incentives in place to reward these employees and ensure their safety so that the nonprofit sector can continue to thrive beyond COVID-19?
Yeah, I wish I could say yes, that we somehow have a pot of money to produce as incentives, and maybe the question didn't come thinking about funding. I would say we did a lot of work to help the nonprofit sector understand the opportunities available through the PPP loans. So we were really looking at how do we support the nonprofit community, and it was how do we help them continue to think about their funding streams, knowing a lot of events happen in the springtime and their budgets would be decreased. We specifically put notes out, and many other funders put notes out to current grantees in nonprofits saying, we will hold your funding firm through the end of the fiscal year. So even if your programming isn't happening, your dollars are still in play, and that should give them a little bit of comfort. And we're still looking for the pivot of, you were surveying our nonprofits. If you have knowledge of nonprofits are fighters. They are optimistic eternally. And so, we have been kind of testing the waters to understand, we don't believe every nonprofit is going to make it to the other side of the COVID-19 pandemic, and kind of looking to see where might there be opportunities for some mergers or some affiliations that just make sense given the state of finances. And what we're getting back resoundingly from the nonprofit community is we're going to be okay. And so I don't think the data is actually going to bear that out, but the mindset and the hearts of the nonprofit community have not yet gotten to a place where they're thinking about anything differently than just continuing to serve community and be around in the next 6 months. So there may be some incentives happening within organizations, but we've really thought about it from how do we keep funding intact and support some good big thinking around operations consolidations, and also some other financial management. There's been some really good technical assistance work that has happened around partnering corporate leaders who have had some extra time with nonprofits to think through cash flow management, things from an executive director position, but not so much from a hands-on staff perspective.
Thank you so much, Jill. Unfortunately, we are running out of time. I would love to answer, there was many more questions, but hopefully we'll get another chance to get together again and answer some of these questions. So again, I would really like to express my heartfelt gratitude to all three panelists for joining us today and for sharing your incredible insights, expertise, and experience with all of us. Importantly, thank you so much for all that you do every day for our community. I would also like to thank all of you in the audience for taking the time to join us today. And I hope you enjoyed and learned from the panelists as much as I did. This webinar is recorded and will be posted shortly. So our next webinar is regarding Indigenous and American Indian communities in COVID-19. And this will be on Wednesday, August 5th at 3 p.m. Eastern Standard Time. And it will be hosted by Dr. Christine Bailey and Dr. Sean Daly. Once again, registration will be required. So thank you all again for joining us today, and I hope you all have a wonderful day. And thank you again to all three panelists.
Thank you for having us.
Thank you.
Thank you so much.
Thank you.